Similar treatments are prescribed for opioid use disorder and opioid overdose, including the Food and Drug Administration (FDA) approved medication methadone, buprenorphine, extended-release naltrexone, and naloxone. Lofexidine, a central 2A adrenergic receptor agonist, was the first non-opioid medication that was approved by the United States FDA for the treatment of opioid withdrawal. Lofe- Lofexidine has fewer prescriptive barriers and comparable efficacy and safety relative to other opioid receptor agonists, but it is generally more expensive. Sparse data are available on the effectiveness of interventions to prevent overdoses that are caused by illicitly manufactured fentanyl. Compared with other opioid related overdoses, illicit fentanyl related overdoses appear to be accompanied by distinct symptoms such as body and chest rigidity dyskinesia and slow or irregular heart rate, which can affect overdoses management such as oxygen provision and appropriate overdoses of naloxone. One study showed that the majority of patients who were presumed to, to experience fentanyl overdoses could be discharged after brief emergency room observation, thus unlike requiring additional naloxone dosing in the emergency room. A retrospective study in Rhode Island showed that 6 months of methadone maintenance protected against death and promoted abstinence in fentanyl-exposed patients, but relapse rates were still high. Buprenorphine is an opioid receptor partial agonist and key opioid receptor agonist that is commonly used to treat opioid use disorder. It also exerts antidepressant and anxiolytic activity and is a promising treatment for neonatal opioid withdrawal syndrome. A retrospective, a retrospective cohort study showed that 6 month treatment retention rates and opioid abstinence rates were not different between individuals who were positive for fentanyl of heroin at baseline before initiating buprenorphine treatment, indicating that buprenorphine may still be beneficial for, for treating fentanyl exposure. Repeat treatment with buprenorphine produce a greater magnitude of antinociceptive tolerance than higher efficacy agonists in rats. Studies in pigeons and rhesus monkeys showed that the amount of tolerance that develop to the reinforcing potency of opioid depends on their efficacy, and the higher efficacy opioid receptor agonist sufentanil was more difficult to antagonize than the low efficacy opioid receptor agonist morphine. Recent studies also show that extended release naltrexone was equally safe and effective as buprenorphine naloxone combination at promoting abstinence and treatment retention once treatment was initiated, but fewer but few participants successfully initiated naloxone treatment. Larger, larger or repeat doses of naloxone are spec- speculated to be requ- re- required for the treatment of fentanyl overdose of this higher affinity for opioid receptors. However, a study of a community naloxone distribution program in Allegheny County showed that the average of doses of naloxone that were administ- administered to reverse overdose did not change between 2013 and 2016, although the incidence of overdoses that were related to fentanyl in its analogs increased during the same time. A retrospective study of the fentanyl epidemic in Chicago showed that doses of naloxone up to 12 milligram may effectively treat fentanyl overdose. Naloxone was shown to reserve transdermal fentanyl overdose induced sedation, the reduction of body temperature, and the reduction of heart rate in dogs. Additionally, seeking emergency medical help was positively associated with overdose victims who receive higher doses of naloxone and rescue breathing of British Columbia, Canada. A survey of 316 street recruited people who use opioids in Baltimore showed that the majority of them perceived the high risk of fentanyl, adulterated heroin, and overdose, but most of them did not often carry naloxone with them. Therefore, harm reduction strategies such as safe injection sites and expansion of a viable opioid agonist treatment and overdose prevention training. Carrying naloxone and not use drugs alone, higher doses or multiple administration of naloxone are needed to control the adverse effects of fentanyl and reduce overdoses reduce overdoses. Previous studies have reported the vaccine consisting of fentanyl hapten conjugate to tetanus toxoid or keyhole limpet emocyanin carry protein, and immunization with this vaccine reduce fentanyl biodistribution to the brain. In blunted, its antinociceptive effects and respiratory depression in rodents. A recent study, a recent study screened and purified monoclonal antibodies for vaccinated mice and found that the 6A4 MAB prevented the acute lethality of fentanyl and reserved both fentanyl and carfentanil induced antinociception and effective as naloxone. In conclusion, the crisis of opioid-related overdoses, especially fentanyl and its analogs, is a major threat to both individual and public health. Respiratory depression, cardiovascular effects, and neuropsychiatric symptoms are associated with fentanyl overdose and lethality.